Yes, thank you. Thank you for your patience, Erin, and thank you for being here. Erin, you have been attending a number of these sessions in the past, so you are definitely not a new member here. But we have been so interested in your work in using, thinking about adaptations, and so look forward to that. I will provide a very brief introduction to you, but I would love you to expand that. Dr. Kenzie is an assistant professor at the Oregon Health Science University School of Public Health at Oregon Oregon Health and Science University, I apologize, a core investigator with the Oregon Rural Practice-Based Research Network, and an affiliate faculty member at the Portland State University Complex Systems Program. She's a system scientist by training and conducts research at the nexus of system science, implementation science, and health equity. And we invited Erin because I have heard about her work in this exact nexus that she describes in her bio for a long time. And I have seen her present, but never in this specific group. So excited to share this. I also will say that I had a wonderful journey with Erin being part of the ACCSIS study, which she's going to use as an example, and excited to see how this was applied in their specific site. Thank you so much, Erin, for doing this, and I will hand it over to you.
Thanks so much, Borsika. You said everything I was going to say in my intro, so I guess. But yeah, I'll just underscore that I am a system scientist. So my PhD is in system science. I come at it from that angle. I am more newly in the implementation science space, but have been working in there for the last few years as well. So, and I will try to get through this relatively quickly and then leave some time for discussion at the end here. All right, so I'm going to go over what is a systems approach, what is Smarter CRC, that was our particular ACCSIS study. I'll walk through a system map we developed to describe the logic of how we saw the Smarter CRC intervention working, and talk about a few adaptations from the study through the lens of that map, and then talk about possible applications or next steps for this approach. So what is a systems approach? So this, systems approach, system science, systems thinking, there's a lot of terms that are related that are kind of under this big umbrella. And, but in a very basic way, it's a way to identify and deal with complexity. And sort of fundamentally, it can be understood as anti-reductionist. So as opposed to sort of standard scientific lens of zooming into a particular relationship or a particular phenomenon and sort of assuming all else is equal, a systems approach says, okay, let's look at that complexity of all those factors affecting what were the phenomenon of interest and try to develop sort of a hypothesis or an understanding of how the system might work in order to better understand how we might influence it. And so it's really focused on the interrelationships between aspects of a system. And we often use system maps or simulation models. You might hear of social network analysis is under this umbrella, agent-based simulation, system dynamics. There's different approaches that are within this. But it's also, it's more than that. And I want to get into a bit around sort of some of the fundamental assumptions underlying this systems approach. And to do this, because of this current audience, I'm going to talk a little bit about implementation science and system science and some of the contrasting assumptions here. But fundamentally, both fields are very diverse. There's different perspectives, different theories in both of these approaches, and they're both trying to create lasting change in social systems. And so I think that's important to remember. So within implementation science, there's a focus on the thing that we hear talk about from Jeff Curran. So this could be an intervention or an implementation strategy, but the innovation or the thing that we're doing to try to improve outcomes is the main unit of analysis. So we talk about certain interventions or strategies being disseminated, and the focus is on what is this particular change or intervention here. And within this lens, context is typically seen as a sort of external influence, something that could hinder or help. And we have ways of classifying context. And again, this is an oversimplification. This is, but just sort of real basic. We think in implementation science, we focus on this change, this intervention or a strategy, and think of context sort of as something that's outside of that. And in system science, we have a different set of assumptions, and we want to instead of seeing context as outside, we see, okay, how do we understand a problem to work? What are the drivers? Why does a problem that we're interested in, such as low colorectal cancer screening rates, why does that problem perpetuate over time? And part of that, we first want to understand what's this usual care or status quo situation? What is going on right now? What are the interacting factors that produce that unwanted behavior? And so we would develop what we would call a dynamic hypothesis, or a hypothesis of how we think the system functions to produce that behavior. And we often use maps or models to try to visualize that. And here, context isn't external. It's the unit of analysis is this hypothesis of how the system works, and that is the context. An intervention is sort of seen as through the lens of how might it change, how might it affect the structure or function of a system. But the intervention is seen as this event, a disruption, a change, to try to get a system from one state to another one. And so these are just some things to keep in mind as we go forward here. And so in this study, we this is a ACCSIS study. So the Accelerating Colorectal Cancer Screening and Follow-up through Implementation Science Consortium had 8 sites throughout the country. And that's how Borsica was working with one. I was working with another in Oregon, funded by the National Cancer Institute. It was a cancer moonshot study. And our study was co-led by Dr. Melinda Davis and Dr. Gloria Coronado. And this is in our study, it was a partnership between 3 coordinated care organizations or Medicaid health plans and local clinics to implement mailed fecal immunochemical testing, which FIT is this at-home fecal testing approach that can be used alternatively to colonoscopy. Typically with colorectal cancer screening, you would go in for colonoscopy. It's quite a process to do that. There's many barriers at the patient level for getting that done. And so FIT is an alternative to that. People can do it at home. It's much more appealing in some ways. And we also use patient navigation for follow-up colonoscopy. So if someone gets a positive FIT screening, they would have to go in for a colonoscopy to follow that up. And let's see. So I'm focusing on the pragmatic trial portion of this study. And so what we did is we developed what's called a hybrid causal loop stock and flow model. This is an approach within the system dynamics umbrella. And it's based on qualitative study data, input from our study team. We did a lot of iteration within our study team to develop a diagram that reflected the logic of how we understood our intervention to work. So sort of a theory of change. And this evolved over time. The one I'm going to be sharing is the one we had at the end of the study. This was funded by the Knight Cancer Institute and the Bridge C2 Center at OHSU. So I'm going to get into this. And so I'm going to walk through this diagram. We're going to start small, build very big, but stick with me for a moment here. So to start at the beginning of the diagram, patients age into screening. And so we have what's called a stock, the rectangle of patients who are in need of colorectal cancer screening. And then from there, we have a flow between that stock and a new stock. So when patients become identified by clinics for screening, they move from one stock to another, from patients in need of screening to patients identified for screening. And again, if all goes well, in this case, and this is sorry, this is a, first I'm going to describe the usual care hypothesis. So we're going to be describing what's the typical way colorectal cancer screening gets done prior to any of the smarter CRC interventions. So this at first is just describing the colonoscopy pathway. So patients become identified for screening colonoscopy. They become in need of colonoscopy. And then kind of moving over to the right, once they're identified as in need, they're referred to clinics, specialty clinics often for colonoscopy. They schedule, and then if all goes well, they're completed, complete their colonoscopy. Some patients are referred to treatment if they are found to have polyps. And then once some patients are also who screen negative are they time back into the beginning, right? So they will time into having another colonoscopy in 10 years. And there's also a little arrow here showing that when you have patients complete colonoscopy, there's also a feedback loop that they're no longer in need of colonoscopy. So we have two feedback loops here, basically saying if you need something and you get it, you no longer need it. And a couple of factors, sort of what we might think of as contextual factors going into this. When we're considering who is identified by clinics for colonoscopy, a factor is patient colorectal cancer risk, and then provider preference for colonoscopy. There's also clinic workflows for screening that go into a few different places. And then over here we have patients are reluctant to get colonoscopy. There can be a language barrier. Bowel prep can be difficult. There's logistical barriers. You have to have someone drive you. And availability of colonoscopy, and particularly in rural areas, can be challenging. Oh, that's I just went up. And then a few more factors that go into this. Patient knowledge of colorectal cancer and screening affects motivation. And one thing too, so these, where the blue arrows are flows of patients through the system, the little gray arrows are informational So this is like, they're understood as causal. So the more difficult the bowel prep, for example, the less people might want to complete the colonoscopy. So that's the negative valence here. Whereas with availability of colonoscopy, if there's more availability, people are more likely to schedule. So you can see we can be really specific on what is the logic here of these variables affecting how patients move through this system. So the other variables we have here are competing medical and life priorities. We heard in our study, particularly for the Native American population and some other groups, that prior trauma or lack of trust in the medical system is a factor. Cultural stigma, health literacy, education, patient rurality can affect the availability and proximity of colonoscopy. And then at the clinic level here, we have clinic, oh, hold on. Yeah, okay, we'll go through these. It's a little out of order, but we have clinic QI and population health capacity affecting workflows, clinic staffing challenges is a factor, clinic rurality, clinic size, system affiliation, EHR capabilities. These are all factors that go into to this. And then we also have, so in addition to this main colonoscopy pathway, there's also two other ways within the usual care scenario that screening can get done. Is Cologuard, which is it's an at-home fecal testing method, but it kind of comes with this package of supports, and it does its own processing. Whereas the visit-based FIT is when someone is given a FIT test in their primary care visit, they go home and they bring it back, they return it, the clinic processes it. So it's a very similar method, but the clinic has a few more steps to complete for that. And so this introduces another couple set of feedback loops around when patients are identified for screening, they can either get routed to screening colonoscopy or one of the visit-based methods. And then there's some challenges with that too, around patients forgetting to bring the test back. Clinics need to be able to process that. Patient can be reluctant to use the home test, but once they do it, they're more likely to do it in the future. So there is this reinforcing loop here around familiarity with FIT, meaning that once they do it, they're more likely to do it in the future. And so this is our hypothesis around usual care. So what are the factors that affect colorectal cancer screening in Oregon in the populations we were looking at, which was largely rural in Oregon? And this is prior to the intervention. And so now I'm going to go a little bit into the mailed fit intervention. The yellow variables here are different strategies, and then the patient navigation intervention, and then some supplemental support. So for the mailed fit intervention, we added this other pathway so patients can be identified for mailed fit. And the Medicaid health plan provides gap lists to clinics. Clinics scrub those lists to identify relevant uh, factors or people who are eligible. And sorry, I just got distracted because I saw my own name in the chat. I wasn't sure what's going on there. So clinics scrub the lists. The health plans in this case mail the fit tests. So there's a partnership there. Fit tests are more private, and when they are mailed, it can be more convenient for folks to return them. And then we also have practice facilitation, which supports the health plan involvement, the knowledge and acceptance of fit, bilingual info sheets, wordless instructions, health plan and clinic outreach. We had health plans also helping support some of the prompt and reminder calls here. And prompt and reminders counteract patients forgetting tests and then patients' reluctance. And so for the patient navigation intervention, basically this intervention, the health plan and the facilitators support the navigation training. Patient navigation creates essentially additional loops here supporting these different steps. So there's support for scheduling and support for completing. It's a series of 6 phone calls. And so the logic here is that it reduces reluctance, it helps people connect to community resources, improves knowledge of CRC and motivation, and kind of addresses some of those logistical barriers. So the idea is it kind of helps move people along parts of that system in which they might otherwise drop out. So here's our, and then some supplemental support. We did health plan clinic meetings, and then some support around fit choice. So zooming out, that was a really quick and dirty overview of our model, but I wanted to get to some other parts here. So in total, this is a hypothesis of how the strategies we used in the study interact with these contextual factors to affect outcomes. It's sort of our theory of change. In a paper we currently have under review for a totally different study on alcohol use screening, we did something similar and we defined implementation mechanisms as connections between one of these strategies and a feedback loop, thinking that, okay, there's a logic between, okay, what are we doing? And then how does it affect the system? And connecting it to a feedback loop means that it's connecting it to a way that people are moved and advanced through the system. And these outflows in the model have implicit feedback loops for reasons that I won't go into now. But so that's a way, there's one thing I'm kind of curious to talk to you all about once we get into this is how this approach could be, like, how does this align with some of the implementation science concepts, like implementation mechanisms, like form and function? This is something I've really been trying to wrap my head around, because these, in a way, you could think of this logic causal structure as the functions of the intervention. You could think of, defining, okay, core functions are ways maybe that people move through here, connections between strategies and those.
Erin, just
And
for a
I'll
moment.
pause real quick. Yeah.
Yeah, thank you so much. One question was in the chat that is very
Sure.
logistical. What kind of software do you use to create
Yes.
this amazing visual? And then
Yep.
the second is, I really love what I see. And I actually was going to ask, how does this relate to causal pathways? And, like there are some like seemingly a little bit more reductionist approaches versus this that acknowledges the complexity, which makes me more excited in some ways, but it sounds like you are thinking around those lines.
Yeah,
Mhm.
absolutely, absolutely. Yeah, it's Kumu is the software. It was originally a social network analysis software, but they have a causal loop framework or stock and loop framework you can use. I put the link in the chat. Um, and so I've been thinking a lot about this around, okay, how does this align, like you say, with some of these other concepts, and especially like causal pathway models, those are out there. And, I think there's a lot of room for alignment. I think it's just it's different starting points, right? So with
Mhm.
this, you're starting with what is your understanding of a particular system in a place at a time, sort of more of a realist kind of mindset. Was called the causal pathway models. From what I understand, it's sort of more taking a snapshot of what is the mechanism for a strategy that could maybe be ported across context or across applications. So I don't think those are in conflict necessarily. I think they could, it's more, are you starting with a deep knowledge of a certain situation and then trying to expand up, or are you trying to look at what the generalizability or what are the capabilities of those specific strategies? And I think there's ways to maybe blend that or have those approaches talk to each other, and I'm hoping to kind of to talk with you all more about that. um Great. So I'm going to get into some examples of how we thought about adaptations within this framework, and then wrap up. But first, I want to say another thing that this was helpful for. So we developed this throughout our study, kind of return to it every once in a while, but there wasn't really a super structure. It was more of a proof of concept. We didn't have a very structured way of having this support implementation. It's something I think we could do in the future. But one thing that was helpful for us was thinking about sustainability and thinking about what was in our study, what were the roles of both the Medicaid health plan and the practice facilitators, and sort of what levers were they pushing in our study that could that for the if the clinics or the health plan wanted to continue this without our help, what sort of things might we need them to sort of internalize, or what might need to be done to make this more sustainable? All right. So, how do we conceptualize adaptations through a system lens? So, just as a sort of anchor point here, I put a definition I found from you, Borsika, up here around adaptation is the degree to which an evidence-based intervention is changed or modified by a user during adoption and implementation to suit the needs of the setting or to improve the fit to local conditions. And so this is again where the language of system science and implementation science could use some alignment. And I think there's a lot of different ways we could think about it. One way could be to think of this feedback structure of an intervention or strategy as its core function, or identifying core functions within that. Um, we could, and then we could consider the extent to which an adaptation might change that feedback structure. So I'm going to go into a couple examples and then sort of zoom out a bit here. So um, here's that mailed fit screening loop. So people are identified for mailed fit, they're mailed a fit, they return the fit, it's processed, and this particular loop shows that they receive normal screening results. And so we had a couple clinics who decided to do incentives, right? So we could map onto this. So when we had intervention or adaptations, we can consider how does this map onto our existing hypothesis, right? And so here, an incentive, we could understand that as, um, supporting people returning the fits. So in addition to these other factors, there's also this incentive. Maybe that can move the needle. This is a very simple, straightforward example. In another example, we're looking at how in our intervention, the Medicaid health plans were the ones coordinating with vendors to do the mailing. And in our second year of implementation, there was a delay. That's what this hash mark means. So they mailed months and months after. There was a series of unfortunate events that led to a very significant mailing delay of months and months. And so when we were talking to clinics, um, what we heard from at least a couple health systems was that because of this delay, they had already scrubbed the list. They already had people sort of in this identified for mailed fit bucket, but they weren't being mailed the fit. Their numbers actually went down during this year because they had already put people in this bucket, and so they put a hold on some of their other population health initiatives around colorectal cancer screening. I think they were doing less in appointments because they knew people were slated for this. And so because people had already been sort of stuck in this stock, we could understand they weren't being routed to other approaches. And so that's one way of understanding this sort of in a dynamic way of how did this delay affect the function of these feedback loops. Another example is when we had a clinic who had an issue. They were concerned about tests being deposited in their PO box and not being processed quickly enough. And so they actually told people, okay, don't mail this back, bring this back in clinic, which created this, so they're not mailing back. They created this new feedback loop essentially, and it interfered with it took away the privacy of the test. The convenience was lower. So you could see that, sort of structurally it eliminated this feedback loop, introduced another one that was, we could assume less ideal here. In a sort of similar but different example here, we had a clinic who had a large Native American population of patients, and they were wanting to try to provide different ways for folks to return their fit kits in order to sort of be more culturally sensitive to meet the needs of their patients. And so they provided a in-person fit return option that was a drop box. That was in addition to the mailing option. So it's essentially creating a new set of feedback loops. It's a new way. It's like an additional way. It's still a change in structure, but it was a way that they felt would better meet the needs of their population. So zooming out, and we could, I have a bunch of examples like that. That's just a few. But so when we were looking through our adaptations, we were seeing some patterns where either it had no effect. So this is like changing who made the patient navigation calls, which fit kit there was. And this is also an opportunity to, if we think something might not have an effect, interrogate that a bit. Are there any unintended consequences? If different people are making the calls, how is that going to land with the patients? Are they going to see that in the same way if it was a medical assistant versus a nurse versus somebody else? So it's an opportunity to kind of look at that. But in theory, some of these are ways, adaptations that might have no effect. There's also adaptations that could strengthen a mechanism. So adding incentives or specific expectations. This was, we had a clinic that said, oh, could you return this by next Tuesday? Or could you, put this in the mail by a certain time, trying to create some structured expectations, and then tailoring to certain populations. Adaptations could weaken mechanisms. So we had clinics that opted out of navigation or didn't send prompts or reminder calls because of clinic staffing pressure. So that weakened those mechanisms. And it could also change structure. So we had some examples where health plans took over some calls, and so that created certain different logic in our intervention. Or changing flows like that mailing delay example. And so thinking here, we could consider how the adaptation might affect system structure or behavior. This approach also allows you to reevaluate, maybe change your hypothesis. I see this as not just a one and done. This is an opportunity to reflect and have a boundary object, an artifact that you can go back to um, continuously in sort of a structured way of interrogating what are our assumptions here? How do we think what we're doing is working or not working? And what might the potential impacts be in the future of a change? So, and it also allows for, again, potential identification of unintended consequences, and also maybe planning potential compensatory strategies. So if you do something that's maybe weakening a mechanism, is there something else you could do that could strengthen that? Is there something that could, if you're impairing you're maybe weakening like you're maybe not doing prompts or reminder calls, maybe you could do something else to help support that fit return, for example. And so I think there's a lot of potential uh, promise here. I think there's a lot of potential work that could be done. Specifically for this approach, I think it could be used in a more structured way to support implementation, used in evaluation of a study, um, could guide study design. But we need a lot of more testing, more trying out of how uh, these sort of structured systems approaches can align with existing implementation approaches, and then some development of best practices as well. So I'll just say thanks, acknowledge some of our funders here, and close out here. Let's see, I can stop sharing. I'm excited to discuss with you all.
Thank you so much, Erin. So exciting. You have no idea how much is going on in everyone's brain right now, thinking, how am I going to use this in my own work? So I will open it up for others to kind of ask questions, because if I take it up the rest of the time, that would not be smart. I also appreciate you leaving so much time for the discussion. A few things I will summarize from the chat, because it might have been very hard for you
Great.
to also
Yeah,
follow.
I
Would
didn't
be,
track it all.
some questions. We talked about the software. I also actually had a sidebar conversation with Kara, who is working on her PhD program and thinking of how this would fit in there. So there might be some request on that. Russ was also specifying, this function and form related discussion. So perhaps a little bit more on that. And then Kristen also kind of jumped in on that. So I might suggest that we talk a little bit more about function form and how this play out there. And um, and then I would say that I will open it up for questions, but perhaps if we could talk about a little bit function form,
Mm-hmm.
what could be some pragmatic uses of this, if you can kind of, recommend about that, and then see what others would like to prioritize as well. Russ, what do you think of that approach?
Sounds good to me.
Okay, super. So everyone is welcome to just kind of come on camera if you are able. And if you want to start with this function and form further discussion, but then others can also unmute themselves for specific questions. And the way that I think that we heard that you are framing that perhaps this is a way that we could actually identify what is a function. Like if we see this complex visual, as I understood, perhaps that can actually be a source of us distinguishing between forms and functions. And generally functions come from like some principles or some understanding of an investigator, but this could be more of an empirical way of identifying functions. Is that a correct interpretation? Or
I think it could be. I don't have my thoughts are definitely evolving here, and I'd love to have some dialogue with you all about it, because I think there's something very the idea of core functions is a very similar idea to what we're doing here. Um, I think when I was trying to think of, okay, how do forms fit in? I mean, I think one thing I was going back to is sort of the core functions and then adaptable periphery, and thinking about that through the lens of, okay, what is supporting these core feedback loops in this intervention, and these core sort of steps of, okay, in this particular one, we need to be able to mail fits. We need to be able to process them. We need to be able, there's certain steps to be able to move people through that process. And thinking about, okay, does a particular change help or hinder that in a way that is significant? I think, that it relates to this idea of functions and forms in a way. I'm not sure, how exactly to pin it down. I'd be interested in hearing what other folks think. I think but yeah, the way I see it is that, like I said, this is a way to sort of anchor in a specific context and then sort of generalize up. And then, some of these other approaches could be used to communicate things and, mechanisms or functions in isolation. One thing I will say though is one thing that I'm interested in doing, I'm in the process of trying to get funding to do some mapping maybe across these ACCSIS sites and develop potentially a template model of, here's colorectal cancer, if you want to implement mailed fit, if you want to implement patient navigation, here are some of these core functions that we find across these various contexts. And here's some different structures that might be in place if you have certain, in certain types of contexts. So I think, in system science, by design, it's very realist, what works in this place at this time. But I think there's ways to, be generalizable about, I think there's ways maybe we can kind of meet in the middle and see what are the patterns that we see with this. Because I'm sure I'm sure when I was walking through there, you probably recognized a lot of that was the same in your access study and probably some that was different. So I guess I'll open it up. Just curious what other thoughts folks have about functions forms.
And I also will say that I don't want to limit this discussion to that. It just seemed like an emerging theme. And so I would say anything that you are interested, if it's okay, I did put some, those of you less familiar with the function and form concept, a few of the basic kind of papers and also a website. Yeah, I mean, this is so exciting. So please unmute anyone with questions. I don't want to fully dominate, although I have a lot that I can ask. Anyone would like to ask a question?
Well, I'll jump in. Again, as Borsika said, we don't want to dominate the full discussion, but first of all, it's a fascinating presentation, Erin, and I really appreciate it. A quick reaction and then maybe a bit of a tangent, but where my mind goes, I'll share with you. My initial reaction was some of these are functions, and I find it really helpful to think about that. But it seemed to me some of the ones that were very specific actions would fit the way I think about forms anyway, which were a subset or a way of enacting the broader function. But I do think it works for me anyway. It fits. The comment was, well, maybe I should pause there. See if you have, I'll pause and see if you have a reaction or a thought to that, or anybody wants to comment on that.
No, I think you're absolutely right. So for example, in the mailed fit intervention, fits need to be mailed, right?
Right.
But it doesn't have to be
Exactly.
the health plans that do it. It could be a study team, it could be the clinic, it could be, so there's not, I don't think, a super straightforward way of saying, oh, all the yellow ones are this and all the square ones are this. But it could be more a way to systematically interrogate, okay, how do we understand, like, what is maybe the core functions here? What is more unique to our case, or what is something that is more immutable, and seeing it not in a vacuum, but through the lens of how it might affect the outcomes.
Yeah, that makes good sense to me. I mean, another one not specific to yours, I think I often think about like providing some type of follow-up or support. And there's all sorts of different ways you could do that in terms of who does that and how, what modality and that sort of thing. I guess I wanted to switch a little bit, transition to something else that you said that I loved at several different times. You're talking about a realist approach and how this fits there. And it seemed to me, thinking about a couple of your bullet points that you had there, that the notion I just kept thinking of a context, mechanism, outcome, relationship fits so well with this type of this type of thinking.
Yeah, you're absolutely right. I think I think system scientists are by nature realists in a lot of ways, and
Yeah.
I think there's a opportunity to learn from and sort of compare notes on strategies around ways of interviewing or ways of evaluating, and kind of borrowing from that from the realist school of thought for sure.
I'm sorry. I would say, and please others come and enrich our conversation, but your idea that there is an opportunity for generalizability in that model, that, what are those common characteristics of the here and now that predict potentially a certain challenge or a certain strategy that would work better. And I was just wondering whether we could go from descriptive to saying, these are usual problem areas, and these are some strategies that work better or worse in certain, structural sense, circumstances or something along those lines.
Yeah, I think there's really an opportunity for using this as sort of a common language to compare across contexts and across instances of implementation. So, like I said, it would be great to see, okay, how did this work in these other ACCSIS studies where there's a lot of similarities, but there's also really key differences based on the local populations and how the study was designed. I'd love to be able to play around a bit more with developing strategies for kind of more guiding people in creating these, or are there ways to, because right now it's like, okay, you need to find someone like me who knows how to do this. It's not the most accessible method out there. So it would be great to be able to kind of grease the wheels of that, or be able to identify, here's some of these main elements. If you have certain these aspects, you might want to look at this. One thing that's cool about Kumu, if anyone is interested in that, is the software is, I should put a link to this diagram in the chat, but you can click on different variables or links and attach information to that. So you could put sources on individual causal links, or attach information in a way that's a bit more interactive. So, and there's also a way to kind of walk people through things. So that can be a good sort of knowledge base, or a way to communicate information in a not linear way that can be useful in some cases.
Thank you so much, Erin. Did you say that you put something in the chat?
I'm in the process.
You are in the
of it.
process.
I'm pulling
Wonderful.
it up.
So
Yeah.
while you do that, because you are still better at multitasking that I cannot do anymore, there is a question from Gretchen. And Gretchen, are you in a good position to unmute so you can ask it?
Yes. Hi. Thank you so
Hi,
much
Erin.
for your talk, Erin. Hi, Borshika. I wonder, I love the early on conversation that we were having as you began about reductionist versus non-reductionist, and, this isn't linear, like the complexity of this type of flow of patients through the system. I just wonder how health systems or providers or insurance companies have received this information. Do they prefer more of a reductionist point of view? Any feedback that you've gotten?
Sure, yeah. And just a quick note too, I think in some of the systems literature, systems methods are presented as, oh, it's this better counteractive to reductionist. And like, no, we need that. We need traditional science. We need these structured approaches to be able to, look at things a certain way. So I don't see one as better than another. It's just a different set of assumptions and a different type of analysis. As far as how people receive it, in this particular study, we didn't engage other stakeholders in this dialogue. We have done that in a number of other studies, and there's this whole field called group model building that is a body of literature around engaging folks in co-designing models like this. And that can work really well when you want to use it as a way to develop a set of a common understanding among a group and it's usually a group that is going to kind of hold that container and affect change in a certain way. This was kind of more of like an analysis within our study team. So that's who participated in this. But when we've done this with other studies, I think there's, we've done sort of the bottom-up co-design. We've also done some where we'll kind of interview folks. This is something where I think is a good sweet spot because it's hard to get providers to spend a lot of time on that. This is not something you can do in a 30-minute meeting. This is something that requires a lot more work. And so kind of the sweet spot that we've done is conduct regular qualitative interviews, create a model, do some iteration within a small dedicated group, and then bring that back for validation within a larger group. So we walk through sort of like I did before, but using some more rich examples that are more accessible to the population you're engaging, and kind of walk through that model. And a lot of times, if you do it well, we have what my colleagues and I call the dramatic spaghetti reveal, where it's like, okay, this is complex. And people are like, yes, it is complex. That's my system. I know it. It's messed up, And so there's this like, a lot of times if you do it well, it is something that a lot of people recognize as reflective of reality. That being said, there's also a lot of ways to do it wrong. You can't just start with the big diagram and expect people to have that be meaningful if they weren't part of creating that. So I think it's tricky when you're dealing with folks who are very busy, and you really need to be strategic about how do you engage them in this process in a meaningful way. And that's something I feel like I'm always learning how to do better myself. I see another question here. Can you say something about how adaptation weakens mechanisms? Some would say adaptation is more about strengthening mechanisms. I think it could go, a lot of our adaptations were we couldn't do this, like we didn't have the staff to do this. So, that weakens things. I think that you could also think about sort of more insidious or unexpected ways of weakening something. You could think of something as neutral, but then, oh, maybe it didn't have that same effect. Or by changing something, maybe you impacted the trust of people, or, like maybe there's factors there that maybe weren't in your original model, but are important for implementation in a way that you didn't appreciate before. So it's a way to kind of account for that.
And I wonder, and I was wondering about this because one of our studies in the VA query program, we looked at flow charts or program, like how things will be done, which were not even close to this, real illustration of what is actually happening, but we would have different time points when they were drawn. And so what we did, we compared the previous to the next, etc., and we looked at differences. So I was just wondering whether, is this something that you create multiple times over time longitudinally, and could it be used to identify adaptations as you are looking at consecutive visualizations?
Yeah, absolutely. I think our diagram definitely evolved as we were going through, became more complex, more factors that we were considering. Some things got deleted as they were, we thought they were important and didn't turn out to, so yeah, it was definitely a reflection. So, I think something important to remember is we all have sets of assumptions about how the world works, right? This is just a way of visualizing that and making that shareable or transparent in a way that if done well, other people can access, and that you could compare. We've also done some in other studies compared what's the mental model or the set of assumptions of one group of people versus another group of people. You could look at providers and patients. You could look at different groups of folks have different assumptions. They see different parts of that system. So yeah, you can look at change over time. You could look at comparing across groups as well.
Wonderful. I think we could spend the rest of our Monday morning together to continue reflecting. I'm thinking about what does it mean in terms of measurement, etc., qualitative, but this was such a great amuse-bouche for those of us who might end up following up with you, Erin. I hope that you are up for it.
Yeah, absolutely.
And so I know that I think you had your email on the slide. So
yeah, I'll put it in the chat too.
Thank you so much. And
just my
again,
last name at OHSU.
Perfect. We are going to post this, and then please expect some emails coming to you before and after the holidays. Thank you for doing this. Thank you everyone for the participation. Look forward to connecting in December.
Well, thank you so much for having me. This is a lot of fun.